I just want to share with you guys. I'm non-clinical, right? But I use it, ChatGPT for health. Although I created my own thing. I had bronchitis, 6 weeks, coughing like a fit. They go, you need to see an ENT. We can't get you in for 4 weeks. I go, I can't wait 4 weeks. So I went in, I self-diagnosed myself, and I self-prescribed myself. And then I finally got in with the ENT after 3 weeks, and he was a young guy. And he was really nice about it. Wrong. Everything. And then he gave me a powerful steroid, right? But would I do it again? Absolutely. I felt empowered, even though he gave me the wrong choice. But that is the dynamic. Now that consumers have access to these tools, I wonder if that helps or does that hurt, the whole process of care.
I think we're still figuring that out, right? But let's be honest, for all the clinicians, we had this before. Well before this, I would have, I worked with parents and children, parents who had come in because they had found an online questionnaire or a resource and have self-diagnosed their child. And I had to explain wrong, to your point, and why that's, but now they feel, I think their arguments are a lot more sophisticated. It's not just a questionnaire, but it is actually, it knows about their child and it's making a rationale for why it's this and not that, whereas you didn't have that before. So I do think there's going to be a little bit of an uphill battle in some of these instances. But I can see, to your point, Gregg, it is empowering.
Welcome to Beyond the Blueprint, a podcast designed to empower healthcare professionals, enabling them to improve care delivery through integrated design and technology innovation. My name is Gregg Malkary. I'm the Managing Director at Lighthouse Health Tech Advisors. This episode is part of our collaboration with AMDIS, the Association of Medical Directors of Information Systems. Whether you're redesigning a hospital, launching a new digital initiative, or just curious about the future of healthcare, then you're in the right place. Let's explore together what's possible when we go beyond the blueprint. Now, before we dive into today's discussion, I want to recognize our valued sponsors who've made Beyond the Blueprint possible, Simplify Medical. With their support, we're able to bring you insightful conversations around healthcare design and innovation. If you enjoyed today's show, I encourage you to subscribe so you never miss a future episode. Today, we're talking about shadow AI usage at point of care. In particular, how physicians are using consumer-grade AI tools like ChatGPT, Claude, and Gemini outside the systems that hospitals can normally monitor or review. So the EHR may show the discharge order, the physician note, the follow-up plan, but may not show whether consumer AI helps shape the decision. Now, according to a recent Walters Kluwer study, 1 in 5 healthcare professionals reported using unauthorized AI tools at work, and 1 in 10 actually for direct patient care. Now, the real leadership risk is if a patient gets worse and the hospital reviews the case, the chart doesn't show whether consumer AI actually influenced the care decision. So to help us unpack this, I've invited 3 nationally recognized informatics leaders. We have Dr. John Lee from HIT Peak Advisors, who's going to help us understand where hospital workflows support physicians and where workarounds begin. We have Dr. Paul Sutton from University of Washington Medicine, who's going to help us understand inpatient decisions under pressure, and Dr. Stephon Proctor from the Children's Hospital of Philadelphia, who's going to help us understand how Gen AI can support physicians without adding more work. So with that, why don't we get started? And we're going to talk about the moment when physicians need answers faster than the hospital's current tools can provide them. So John, I'm going to throw this first question to you. When physicians are under pressure, what kinds of care decisions might they ask ChatGPT before the hospital ever sees the question? Actually, let me take that back. I said ChatGPT. So use that as a proxy for any Gen AI related tool.
I would actually extend that to other tools. Actually, so for me, one of the most frequent external tool that I use is MD which is not an artificial intelligence tool.
Yeah.
Concept is very much the same. in that I will formulate some sort of conceptualized risk score. The patient needs to be, I need to consider pulmonary embolus on the patient. And then I will do that calculation in ChatGPT, transpose it into my note, and then I'm good to go. That's a pretty innocuous way of approaching things, and I think it's from a privacy perspective, it's pretty safe.
Yeah.
But I also know colleagues who take entire notes and dump it into ChatGPT, not even Doximity or OpenEvidence, just commercial ChatGPT,
Right.
and say, rewrite this note to maximize my E&M coding. I kid you not. They actually have a prompt that they put in, and it works well for that.
Yeah.
But it's of concerning privacy ramifications.
Okay. I like that. Now I live in Stanford Mafia country here, right? So I get to walk with all the local docs. Everybody's using it. Maybe you guys can talk about that. Paul, Stephon,
Yeah.
what are you seeing from your lens in terms of either your own usage or what you're hearing from colleagues? What is going on behind the scenes? Is this gaining traction? Is this good news? Is it bad news? I'd love to get your perspective.
Well, I think the question of whether it's good news or bad news remains open at this point, but it's being, if you think about digital natives, and I live in I'm in an academic medical center where there are residents and fellows at the point of care, and they are using these tools all the time for all kinds of things, whether it's planning a vacation or looking up how to renally adjust a medication. I think that it's just part and parcel of their daily lives. The thing that's interesting to me, sort of stepping back, is even beyond MedCalc, which is sort of a relatively modern web-based iteration of sort of codifying existing risk stratification tools and medical calculators. If you go back to my time in the days before EHRs, we all carried pocket manuals of one sort or another that were our sort of go-to references when we felt a little bit over our heads, would reach into our pocket and pull out the Washington Manual or the Harriet Lane Guide, or, surgeon, neurologists each had their own sets of tools. And so people have been making decisions, clinical decisions, and acting upon them based on information sources. Of course, those were dedicated medical resources, which I think is distinct from commercial LLMs, but, people have relied on these things forever.
Yeah. The technology really is so engaging, though, right? Everyone can have it in their pocket easily, hands down. It wasn't locked behind a license that your organization needed to provision. You could just go to the App Store or pull up a web page for these. And there's something dynamic about this is, Paul was talking about how we had these medical knowledge resources, which were usually, paper and pencil or even a website. But in John's example, it's very dynamic. He can describe the characteristics of this patient and what he wants from that. You couldn't do that with paper, right? You either had to cross-reference between a couple of different pages if you're looking at a differential, but now it's pretty open-ended and engaging. And so the barrier to entry has lowered in terms of getting access to the technology. But then in terms of the interaction with the technology, both of those together have made it to where you're seeing high rates of people using it, whether it's, something your institution has given you it's given you a protected version of it, or whether you're just opening up any of these resources and typing in your questions.
Now, the two tools I've heard about that docs are using increasingly at point of care. One is OpenEvidence, and the other is a tool that came out of Providence Health called MedPearl. And I think Evie Cunningham's group. What are your thoughts on those types of tools? From what I understand, this is really groundbreaking stuff that really enables the clinician at point of care to make better care decisions. But I would love to get your guys' thoughts.
I think expanding on what Stephon said, I think the ability to ask higher order questions and to iterate in a conversational way to ask the next question and the next question with these tools is really remarkable. And I think I haven't used I've used OpenEvidence some, and I think it is a pretty remarkable resource. It does, it's quite good. And I think that they have tried to curate legitimate medical resources. You can point to the resources and actually look at sort of retrieval augmented generation of responses, so that you can go back and look at the original source. And I think that's a useful feature. The one thing I will say is that we have, over the years, excluded pharmacy reps and from our institution, and our residents don't see them. They don't provide lunches. They don't provide pens and whatever that they used to in the bad old days. But OpenEvidence is supported through pharmacy advertising, and it's quite targeted. It knows a lot about me. It knows my national provider number, my NPI. It knows what other searches I've done. It knows a lot about my practice, I assume. So it can really target ads to me in a very direct way, which is quite different from other medical resources.
You know what might be useful? Maybe we can get some real examples of how you're seeing maybe consumer AI actually being utilized at point of care. And it could be somebody else that you've seen, just to give me an example of, of your purview, and perhaps how this maps against how the tools of the EHR may or may not be keeping up with the reality of what's going on the ground.
So, I told you my colleagues not so good utilization of the tool, but I've used it for, a common use case for me is that if there isn't an explicit discharge instruction that exists within our kind of the regular canned instructions, I'll put some basic clinical information into OpenEvidence and say, I'm in the ER, I'm discharging a patient, create discharge instructions at an 8th grade level for me. And it'll do that. It's super specific to what the problem is. And I have found that a particular utility. The other interesting thing that I've used it for is we are rebuilding Epic, and the things that we're doing is we're creating these things called preference lists for our physicians. These are lists of orders that are commonly used for a particular physician. So what I did was I went in and I looked at all the different types of meds and procedures and orders that a particular specialty would order. Then I exported that list, and then I dumped it into OpenEvidence, put in a prompt and said, I am a family practice doctor. I'm an orthopedic surgeon. I'm an ENT. What are the common ways that I would use this list of medications, and give me the ordering profile, like how many to prescribe, the dose, and whatever. And so what that allowed me to do then is I still had to key everything in, but I didn't have the mental workload of, God, how many, what sort of ways will an ENT use this typical nasal steroid just once a day or twice a day? And it makes that cognitive load way easier.
Okay, so you're an ED doc, you're in your 18th hour. I don't know if that's still true, about how long docs will work. I did read The Making of a Surgeon, though. And you're really busy, right? The ED's full, right? Does it save you time? Is the information coming out of it now accurate? I don't hear the term hallucinations anymore. Maybe it still exists, but I think the tools are getting much better right now.
Well, I think the hallucinations exist. A lot of it depends on the tool that you use, and also the data that feeds into the tools. OpenEvidence is a retrieval augmented platform, so the risk of hallucination is really pretty minimal.
Yeah.
But if you have it out on ChatGPT, it's just ingesting all sorts of varied parts of it, it'll come up with something that's really looks really authoritative, but is complete. Can I swear?
You can do anything you want, right?
Okay, it's complete bullshit.
Okay. Stan, what about at CHOP? What are you finding at
Yeah.
CHOP in terms of either yourself or colleagues or residents? What are some of the trend lines of how it might be used? Are you pleased with? Maybe this is a good thing, right? If the tools being provided are not adequate, hey, this is a nice creative workaround, as long as there's a way for us to track uh, how we came up with the decision, the clinical care decision.
So we're in a unique position in that we sort of have the gamut, right? So we have a lot of the EHR Epic provided AI tools already. So our users have access to drafting tools, summarization tools, and so on. Not maybe all of them at all different levels. You had brought up trainees.
Right.
So our users do have those access, but then we can't, of course, stop them from using OpenEvidence and everything like that. So it's really our philosophy is, responsibly evaluate these tools and give them access, because of course, if we don't give them access, especially in the EHR, they're just going to look for it elsewhere. So it's really been a positive in my eyes to allow more access to these tools and allow users to choose the one that's best for them. We're seeing, of course, some of the same benefits that others are seeing with ambient scribes. We're seeing a huge uptake in the chart summarization. I think people are really realizing just how big of a pain point that is, but it was a little bit more silent. You didn't really know what you didn't know until you saw what an AI summary could do in terms of how much data it could, read through in a matter of seconds. And so I think that's been a unique value point for AI that Ambient and more of these chat interfaces got a lot of the attention, but I do think you're going to start to see that these summarization features are kind of the next big area where a lot of our cognitive work is being, supplemented by. And I'm hoping that what you're starting to see is that a lot of these tools start to blend together, that your AI scribing tool has enough of the information that your AI summary tool did, right? Because context matters. The more you know about the patient and their history, the more accurate the recommendations or the guidance is going to be. And what we have right now is bits and pieces, right? You go to OpenEvidence, you have to tell it about your patient, but that's only as much as you put in there, right? Even if these tools are embedded in your EHR, these tools are still relatively independent and don't talk to each other. But I'm hopeful that these will start to kind of combine into a synergy so that it starts to have a wider view of the patient, and that when it's grounded by knowledge bases such as UpToDate and others, then they'll just become that much more powerful.
Stephon, do you think that is the direction that we will eventually see with Agent Factory, either with Epic released agentic workflows or internally curated and created internally within Epic, that pulls in the note, surfaces up an MD calculator, and then says you need to do X, Y, and Z based on content that it pulls in from OpenEvidence or UpToDate?
It seems technically possible. So for those who don't know, Epic has a software suite that they're building up called Agent Factory, which allows analysts and builders to tie together a bunch of different Epic activities as well as prompts, just like you would with like a ChatGPT, as well as agents. And really think of it almost as like a USB, the way that you string the dongles together. It's going to make kind of that custom connection, so to speak. And really, the sky's the limit. To John's point is, really, if you can connect it to a certain knowledge base or a certain set of actions or a certain part of the patient's history, it should make a lot more of a powerful agent tool.
Can you give us some examples of maybe how you've used Agent Factory to create some type of agents that you're actually using today, or maybe your vision for the future of how you may want to use agentic AI to help support clinical workflows to support interdisciplinary teams?
I was in a meeting with some Epic folks talking about Factory just before this.
Oh, really?
And their developers, or actually one of their customer representatives, happened to mention that they've been working on this since October of 2025. So this is really brand new stuff, and it's moving at an incredible pace. And I think the potential, as Stephon mentions, is incredible. but it's still in its, I think, relative infancy. But you can imagine it doing things like helping with appointments if people meet certain criteria, or if a request for a refill comes in, if you can either fulfill that automatically or route it to the appropriate person at the appropriate place. If you think about research applications, if it can scan a chart and look for eligibility, or if it can appropriately say that this lab test for this patient should be assigned to the research study and not billed to the insurance agent. And things like, I mean, the possibilities are virtually endless, but the idea is it can actually take information from the chart that's very patient specific and apply rules and then take actions that are sort of automated. Then it gets into the realm of the FDA's, recent rulings around software as a medical device, that when things happen without human intervention, that's really sort of a medical device that the FDA should have some oversight and make sure that it performs at a certain level of accuracy.
Yeah, I
Stephon,
think
what are your biggest concerns though about, because you just said it's in its infancy. What are your biggest concerns of where it is today, how it may evolve? Are they providing you enough of the tools, or do you have to customize everything to have these really complex workflows?
Right now, they actually, the people who are typing things for this agent factory are Epic representatives. They're the people actually doing it. So right now, it's very closely held and sort of in utero. But I suspect that the future of this is, you can imagine people who are really expert with these tools that'll be at the nexus of developing agents and in individual institutions. And then the challenge is, I'm in a relatively research, it's a state facility, so not resource rich, but we're a big complex organization that has a large IT enterprise. And so, we probably have the ability to do this. But if you're a community hospital, perhaps you're going to rely on what Epic can provide you, I suspect.
Yeah, I think you're seeing the evolution of generative AI going primarily from knowing, right? These sort of are, these technologies are trained on a lot of knowledge and they know a good deal. And then what agents, it transitions you into doing. And so if you think about with the EHR, yes, some of these tools that we have are doing things, right? It's drafting, but it's not agentically doing them, like doing them without me saying, you need to do this and this and this. And while that can be really powerful, that opens up huge risk, right? I was trying to think of an analogy, and it would almost be like if we wanted to learn about woodworking in a classroom with no tools, we were just reading about woodworking. You'd say, well, the risk of getting harmed is pretty minimal. You could probably learn a lot, but you're not going to learn as much. But if I take you next door to the workshop where we have a lot of tools that have saws and hammers and everything like that, the risk goes up. You can build some really amazing things in this workshop, but you can also get yourself injured. And that's where governance is really going to have to come in, guardrails at the software layer, but also who has access to build these, or what can they do? Because you can build something that can contact a patient, or you can have it interact with certain parts of the chart. But maybe we actually had guardrails in the chart to begin with to stop providers from doing something, but then the agent, if it doesn't have those same guardrails, it can do that action. So it's going to be really interesting to see how this evolves.
Who's at the table making these decisions? Like, hey, let's just go gangbusters, right? We've got all the foundation tools from Epic. Let's just do everything. So who's the rhyme or reason? Who's got the vision? And who wants to put the brakes on this? Hey, look, this produces phenomenal risk for the organization, right? Let's think about this for another 3 years and maybe we'll implement some stuff.
It's quite variable. And I don't know about you, Stephon and Paul, but I find that most often the people making the decisions are the ones who are most poorly equipped to make the decisions.
Can you elaborate on that, John? Who are, and what kind of roles might the wrong person be who may be the one who may have the influence and access to the budget, but is not the right person to make the decisions?
So let me give you a concrete example. I was sitting with a physician executive.
Yeah.
And I was, as you won't be surprised that I was talking to him about data governance. And his response was, well, I don't think we should be putting any resources to that sort of effort because AI is going to fix our data governance for us. And I tried to explain to him, no, it's actually you have to get the data governance first and then the AI will work. But it was a lost cause at that point. But that's that's one of the big concerns of mine is that there's a lot of shiny object chasing going on, and oftentimes those shiny objects are chased by people who don't know anything about the technology.
Is there somebody leading the charge, right? Is it the CMIO? Is it
it's quite again, it's quite variable.
Who sees the possibilities and can actually connect it right back to the metrics of the hospital on how this is going to improve heads to beds at the highest possible gross margins. Like, who's the one making these decisions?
So the thing is, what you just described is kind of the a shiny object approach, in that a lot of people are looking at endpoint solutions to fix broken processes that perhaps shouldn't even be there. And if we can use the technology to actually redesign things from the ground up, we will be in a better long-term place. But it's also a much more difficult argument to make, especially if somebody's looking mainly at quarterly revenues.
Actually, I like the way you just framed that. Maybe that should be the next question for you guys. What's the low-hanging fruit? What should we be going after as it relates to agentic AI? Is there a low-hanging fruit that we should be going for now? Like, for example, we had a whole podcast with Sutter Health about ambient listening and how this was a platform and how they were going to leverage this to actually optimize right coding for the coding. So, that's where that's kind of the direction they were going. But what do you guys see? What is short-term table stakes that every organization, no, I take that back, specific health systems in the top 1,000 hospitals should be going after today?
And it seems like, just to clarify that question, because you can go from, your general, the tools that are available now to something more in the future, right? Like, because when I think about agentic, I still think the huge benefit is really the care that we provide outside of individual face-to-face admissions or visits, right? Remote patient monitoring is really hard to scale with humans. Hands down, you just cannot hire enough people to check in with someone who was discharged, someone after a surgery, someone in between their psychiatric appointments, and gathering how they're doing, gathering information, making sure that they know how to use the device that you sent them home with, using AI to help supplement that so that they probably don't come back to the hospital because they were, not following through on their recommendations. I really do think that is an area of like staffing that the technology, if you've ever kind of interacted with a voice agent, they're getting incredibly good at this time. And the fact that they will soon be able to interact back with the patient's chart, file a note about what that interaction was like, notify someone on the nursing team if there's been an escalation or whatever it is. That is a big area where, like I said, you can't easily scale that with humans, but you can easily scale that with AI. If you flip it back to technologies that we have now, I think it's pretty clear that the benefits that we're seeing with ambient technologies, even if there's not consistent ROI in terms of financial, you're getting a lot of ROI on your provider's experience. I think most of the time you're seeing across many surveys and studies, there is that reduction in cognitive burden, wellness, and burnout improvement there as well. So if you were kind of to figure out where to devote your resources, I think that's pretty clear. I would also second the chart summarization tools, depending on whether it's a third-party vendor or within your EHR, because that's also a very big mental unlock that I would say is pretty accessible across all roles.
Actually,
I would add to the ambient. Let me just the ambient thing. I think is becoming a key in terms of recruitment and retention. It is sort of a base expectation. If you're out looking for a job, you're going to choose the institution that provides ambient technology. And I think that becomes a great expense to organizations in terms of brain drain and in terms of the cost of replacing people and so on. The one thing I want to say about the summarization tools, whether it's discharge summary preparation or summarization of a patient chart, is when those systems hallucinate, they are memorializing those hallucinations in the chart. People can either transcribe what the summarization tool tells them that may be incorrect or off in some way, or they may copy and paste, heaven forbid, what the summarization tool provides. And we've been looking at these tools a little bit, and there is some rate of hallucination. And so that's a potential problem. The second thing is that the people most likely to use the summarization tools are people who are less familiar with the individual. Either I'm the resident in the late evening, for example, who's writing a discharge summary. This is not my primary patient. I don't know them particularly well. I'm truly reliant, or they've had a long length of stay. I'm truly reliant on the summarization tool to help me with this. But I'm less prepared to verify the accuracy of the information in that instance.
Paul, I had
and
a
then
question.
the one last thing I want to say that I'm seeing people use these commercial things for is translation of patient instructions or discharge instructions. And that I don't think is a good idea right now.
Elaborate on that last point. That was, I thought that would be a no-brainer, but can you elaborate?
Yeah.
Yeah.
I think it is a no-brainer in terms of, boy, that would be great.
Yeah.
But I think that right now the requirement for a translation is that it's verified by somebody who is a certified medical interpreter. And folks are just using, send it out to the, commercial LLM of your choice and come back with something in Lithuanian.
Oh, okay. Got it.
Or Russian, which is a little hard to verify.
Yeah,
well,
interesting. Go on.
The rate of hallucination is not huge,
no,
but it's significant enough that it could be really problematic, embarrassing, and maybe medical legally very detrimental to your organization.
So I guess what I'm hearing is we need to have a human in the loop, right? There needs to be somebody with clinical judgment who'll take the time to at least evaluate the output of what it is. Now, the reason I bring this up is because we had a podcast about 3 months ago with 4 medical school deans, right? And they were talking about the digital natives coming into the programs. And the attendings need to be able to evaluate, are they gaining the clinical expertise and experience, or are they just taking at face value what's kind of coming out? Well, what are your thoughts about this?
I think de-skilling is an enormous problem.
De-skilling. I've never heard that term before.
Meaning you don't know how to do certain things because technology has assumed that role in your life. And to the point where, so I had a bit of a vigorous exchange with somebody recently.
Yeah.
Certainly through most of medical school, and maybe even through internship, you should not be allowed to use a note template. You should have to write every single note from scratch and actually process everything. And I would actually even say, even write it out by hand and get the cognitive connections of how to think. Don't want you to do that for your entire career, but you need to learn how to think. You need to know that the reason why you put a past medical history into an H&P is so you can go through the list of historical items and figure out what's important, what's not. Not just because it's a perfunctory thing that you do for an H&P and you just bring it in by SmartLink and then you can go on with your life.
With all these advanced tools coming out, should we maybe adapt how we train the next generation of docs, right? Leveraging the technologies that are available. There is a compelling argument, John, that that's exactly what they need to do. They need to suffer through the process.
This is a national discussion. Like every organization is struggling with this. And I don't think any of us have figured it out. But John, there's something I agree with there. And I've been thinking about this and formulating, like, what is it when I'm working with trainees that I'm trying to do what I'm teaching? And there is a little bit of, I'm instilling some friction, right? Like, instead of giving them the answer, I'm asking them what their thoughts are. And I'm almost in a Socratic type of way, trying to assess how they're thinking of it. But that's friction, right? I could just tell them exactly what I think the plan is, but then they haven't learned anything from that. They haven't gone through that process of conceptualizing it like you're thinking. And you brought up an interesting point of the notes are sort of either giving or not giving friction. And your ultimate example, right, if we take it to its absolute with a blank note template, is you're providing the most friction. They have to work really hard to get to that endpoint versus all of us now probably have note templates that are highly structured and tell you exactly what domains you need to be thinking of and drop downs and all of that. And we're reducing the friction. So it's a compelling kind of like thought experiment. And I've wondered, even with these tools, is there a way for our learners to have friction, right? If they were to use something like OpenEvidence, instead of it maybe just giving them its response, maybe it's a little bit more like, if you've ever used ChatGPT as a study mode, and its goal with that, especially with education, like in high schools and college, is to not give you the answer, but to help support you in thinking through until you get to the answer. Because I don't think we're going to get to, John, unfortunately, I don't think we're going to get to the point of blank note templates. And we know that these trainees have access to OpenEvidence and everything right now. So is there a middle ground where we can somehow add some friction in there so they don't have the de-skilling until we get to a point where we feel competent, that they are competent enough to not need that friction?
That's really good insight.
That's kind of the notion that we've had as we think about particularly our early students and trainees. Is there some kind of competency-based assessment that we can provide that says, okay, you've learned the basic skill, now you're ready to use these tools?
The other flip side to this, though, is that the level of data science training, from what I understand, I'm not in academic environment, but the data science training in medical school, from what I understand, is still limited to the basic statistical, like p-value with a chi-square test, and all that, basically how to read a paper. Not you have the predictive model. What are the inputs and what sort of mathematical techniques are being used to actually send something as a recommendation to you, or do you even know what a transformer is? Because and those decisions are being presented to us as practitioners. We certainly needed to know what the Krebs cycle to learn how to manage DKA, but I wouldn't be able to spit out the exact details to you. But I generally know what is happening so that I can actually do the right thing. I would contend that we have to do the similar sort of thing and raise some sort of data science, basic science training, along with biochemistry, along with anatomy, along with
Is that kind of training being introduced into the medical school and the residency training? Are you seeing that?
I would ask my two academic colleagues.
We're beginning to do that. I mean, there are medical education careers being built in this domain, and we have people who are giving a lot of thought to this, like how do we prepare our medical students and our residents for practice in an AI-rich environment? How do we? I mean, I think that one of the challenges that I think of is you get the expectation is that I review anything that my ambient dictation, my ambient scribe provides for me in a note, and I do. I do try to do that carefully. But as I get more and more used to this, and as the tools probably get better over time, is that level of scrutiny going to decrease to a point that's not in the patient's best interest? So I think part of this is our fiduciary duty, our professionalism, right? This is an expectation that we care about this and pay attention to this and use these tools responsibly. And I think that's part of the education, not just the data science, but the culture of using these in a professional setting.
And we do have to consider making it wider, right? Because many of our attendings don't know the same things that you were talking about, John, but they're using these technologies. And how do you then guide, a resident that you're working with on how to understand why that confabulation happened? But a lot of users who are using them now don't know how to
True.
spot those things and how to be critical about it. So it leads this kind of gap, right? Like, yes, we want it as part of medical education, but what about all of us who have already finished our education?
Great
We've
point.
never finished.
All right, I'm gonna pivot here as we're toward the end. We have something called peer challenge, and what I normally do in these is that I let one of you guys ask your other two colleagues, 'cause the question comes across a lot differently. So I'm gonna let John ask you guys a question that he finds interesting. It might be really interesting to our audience. So, John, what would you like to ask Paul and Stephon on this topic that might be of value to our informatics leaders listening today?
So actually, this particular question has come up a lot, and right along the themes of what we've been discussing is how do we get to a point where this sort of shadow AI becomes less of an issue? Because institutionally, our organizations tend to be very conservative and say, no, we're not going to let that in. But people are going to use it anyways. What do we need to do to change the culture or change the administrative mindset, our legal and privacy colleagues? What do we need to do to actually make it so that it's as integral part of our medical operations as it is, at least my outside? I mean, every day in the morning, I have a Claude command that tells me, what do I need to do today? And it aggregates everything for me and tells me what I need to do.
Yeah, my first reaction is, maybe this is the psychologist in me, is what are they reacting to? Like, why are all of the stakeholders that you listed saying no to these technologies, despite them already being available? And it comes down to concerns about risk. And how can we continue to find ways to mitigate that risk and also educate all those stakeholders that the risk is actually going down? I think you probably have seen this. A lot of people still hold the early days of ChatGPT against all LLMs, right? The first couple of models had errors with things like confabulations. Bias was a much bigger deal than it was then. And I don't think really many people have updated their schema or their biases about these models. And they continue into this day where these more advanced models, I think Paul was saying as well, is like you're just seeing a lot less. And especially now that these technologies are being backed by medical evidence or more of the patient's data, they're becoming more accurate. And I'm putting that in air quotes because accuracy is a whole nother topic. But they're becoming more helpful and less, the risk is going down. And so I do wonder, instead of trying to convince them of the benefits, which I think we've all been doing that, how can we focus on the other end and talk about whether the risk are actually as risky as before? And kind of then take it further is how can we continue to stay on top of that to continue to have those conversations that even today's risk on this day are going to be less than, hopefully, with more advanced models 6 months from now.
It's almost like a self-driving vehicle argument.
Yep.
I mean, our expectation of a self-driving vehicle, it's clear that, the accident risk probably is lower than a driver. But if a robot makes an error and runs over, your pets, the harm is greater than if it was a human making an accident, for example, or just making an error. I think about Stephon's earlier point about a reliable LLM model that is tuned to, domain specific, in our case, medicine or psychology, or that is integrated into the EHR, that has the ability to see the patient's chart and all of its complexity. That, I think, is the way that it becomes both a richer tool and probably lowers risk overall. I say right now, given the existing commercial models, what we've done is we have an instance of a commercial LLM behind our firewall that we have you have to sign a use agreement that specifies that you're responsible for any, clinical decisions that you make using this tool, and describe some of the limitations of it. It's, I would say that that's an early step in the responsible and safe use of these tools, because it still is just, it's a commercial LLM. But it's the first step in sort of bringing it under the tent of the institution.
So just as a follow-up question then, the external non-medical environment is moving so quickly. Do you ever think that we'll get to a point where we'll have a critical mass of people only using AI tools only within our protected medical environments?
I don't think so. I mean, you cannot use a browser without, using these tools, right? So this is everybody's experience with these tools all day, every day. So I don't think we'll escape, at least not in the foreseeable future.
I agree.
Hey guys, I think we're out of time. This is a great dialogue. I realize we're way over. I do want to have one last lightning round, 30 seconds each. I want you to give a piece of advice to informatics leaders who are listening today, what they may want to consider working on Monday as a result of some of the dialogue we've had. John, what are your thoughts? What thought would you like to
what do you think? What do you think I'm going to say, Greg?
Go ahead.
Data governance, get your basics teed up. If you do that, if you map out all your processes and clean up all that stuff first, everything else falls into place.
Paul, what are your thoughts?
Yeah, I think governance, but I think kind of a top-down, just sort of embracing our responsibility to use these tools well, in that in the interest of our responsibility to patients, that each of us as individuals has to use these well. And I think that culture really has to ramify throughout an organization. But I do think governance is fundamental to that, as well as strong leadership.
Stephon, what are your thoughts?
Yeah, I think as an organization, you have to make this personal decision about whether on this continuum of adopting very quickly and with little governance or verification, and being in the back of the pack and basically just stepping out and just waiting for this to resolve itself, is finding that middle ground where we are exploring the potential of these in a responsible way. Because my concern is if you choose to kind of step out of it, you're missing really the benefits for your clinicians as well as your patients. But if you're moving too fast, then you're increasing risk. You're sort of doing a disservice to really what we're trying to do, which is improve the care of our patients, as Paul was saying. So I really, as an organization, step back and really think about where you fall in that continuum and see if you can find more of a middle ground so you're getting the pros as well as de-risking it.
Excellent. Well, I want to thank John, Paul, and Stephon for being with us today. Their insights and experience have been outstanding. This is Gregg Malkary. I want to thank you again for joining us on Beyond the Blueprint.
Thank you.
Thank you for listening to Beyond the Blueprint. Together, we're exploring how thoughtful design can simplify complexity, enhance patient care, and create meaningful change. If you found value in today's episode, make sure to subscribe and leave a review in order to help us continue the conversation. Let's reimagine healthcare together on Beyond the Blueprint.